Hold on one second. Let me just put a break into the conversation just to remind people that this is Curbside Consult, and I'm talking with Jonathan Cohn, and we're now talking about the issue of how narrow networks should be in people's insurance. And you wrote a piece about Cedars-Sinai Hospital in Los Angeles and how many people were very disappointed to discover that their exchange plans didn't include that hospital. If maybe you could say a little bit about that.
Yeah, so this is something that's happening in a lot of communities. Sinai in Los Angeles is a very well-known hospital. It's in the sort of western side of Los Angeles. It's well known because it's the hospital of the stars. Jodie Foster had her baby there. Madonna, had her surgery. It's got a very, very wealthy, very generous donor base. It's massive. It's one of these very large hospitals. It's got its own art collection. It's a very nice, good hospital that can attract it. This is true of any top hospital in the United States now. They do a brisk business in the sort of elite, and they will often, I don't know which specific hospitals are like this, but I would willing to bet if you went down the list of, Mass General and the Brigham in Boston and Sloan Kettering and Hopkins in Baltimore and Northwestern Chicago, MD Anderson in Houston, all the cancer hospitals. Mm-hmm. They all have wings, and these are where the Saudi princes over and get their care and whatever. And that's fine. Hey, look, if there's, royalty overseas that wants to pay out of pocket billions of dollars important to the American healthcare system, who's to object, right? I mean, that's fine.
We have I should say, by the way, we have a new $700 million pavilion in our shop as well, and it is quite beautiful, and it has a wonderful. The next time you're in Chicago, I'll take you up to the dining area up on the 7th floor, or the top floor actually. And
and I believe you've been to Ann Arbor recently. Perhaps you've seen the glistening new Children's Hospital at the University of Michigan Medical Center. And look, these are very good hospitals. I mean, and they do some great work. Cedars is no different. For the really high end stuff, the most complicated cases, the cancers that don't respond to the normal protocols, the people come in with 4 different, very serious when you really need the sort of the people who do the most complicated cases and do them regularly, right? I mean, in medicine, that's the key thing, right? If you have a complicated case, you want to go to someone who's seen it before, who does these. You get a transplant, you don't want someone who does 3 transplants a year, you want someone who does 50. And that's what those hospitals should be there for. And you want to go there, and we want them to thrive and to drive research and do all that. And Cedars, great hospital for all that stuff. Cedars is really, really, really expensive. It's among the most expensive hospitals in the whole country, not just in Southern California. Because of their reputation, they're able to basically say to insurance companies, hey, we don't have to put up with your discounts. You don't want to send your people here, fine. People won't like it, and sure enough, they don't. The flip side is that, the insurance companies then pick other hospitals. Now, the ACA, the Affordable Care Act, does have a kind of network adequacy requirement in it. Mm-hmm. Like every regulation in the law, it has not been written in a way that would be as strong as I personally would like it, but it does say, you have to be able to, you have to have a children's hospital or a place that does special, pediatric specialty. So in Los Angeles, for example, the insurance plans that don't cover Cedars, they will send you to either UCLA or USC, which are both excellent teaching hospitals, right? And or go to Kaiser West, Kaiser Permanente.
Do they have a good art collection in those places?
They don't.
Well,
they're cheaper. They are cheaper, and you can get to see the specialists now. So on the one hand, when you think about it, most people are able to get to a provider, at least at the hospital level, that will provide the care they want. The flip side is, a lot of people don't worry about hospitals; they worry about their doctors, right? People want to be able to see the doctor they want to see. And they, maybe they had a doctor before, and now the exchange plans don't include that doctor because these exchange plans are not paying a lot of money to the doctors. And, as somebody who cares about public health, someone who talks and interviews people, like you, we do, that's bad. Yeah. And that's not just bad because it makes these people, it causes inconvenience, or not just bad because it makes them uncomfortable, but it's bad for care. I mean, if you've got a long-standing relationship with a physician, you want to keep that. It's good for your health. And sometimes there really are, even in a big place like Los Angeles, there may only be a few providers who are really, know what you want. As a public health expert, I'm willing to say, I'm not a public health expert. As someone who talks to public health experts like you, I am willing to say confidently that most people who think their doctor is indispensable are probably wrong. I say that as the son of a doctor who I think is fantastic, and I went to college with one, and lots of my doctors. And
we like doctors.
I like doctors. I really do. But they're not as indispensable. Most, everybody thinks their physician is like the greatest in the world. They're probably not. But there are some people, and they tend to be the ones with chronic illness, a lot of them have found their way to the people who are best, and you don't want them to have to lose it. And this is one of the areas where I think about improving the law. I can say analytically, well, this was happening already. Physicians go on and off networks all the time. We may see some acceleration again with the exchange plans, but this was happening already. There are other ways to do it, though. I mean, one of the more interesting things looking forward is, at least at the hospital level, who's not having a problem with narrow networks is the state of Maryland. Now, why doesn't the state of Maryland have a problem with the hospital? Because they tell every hospital, they just set the fees. They just say, hospitals, here's what you're making if you're in the state of Maryland. So insurers don't compete. The government sets the prices. Now, any free marketers on this call have just, their heads have exploded. That's socialism. It is government price setting. But it's in Maryland. Works pretty well in Maryland. Johns Hopkins is in Maryland. Great hospital. They seem to do just fine with it.
Just to remind folks, this is Curbside Consult. I'm Harold Pollack interviewing Jonathan Cohn, and we just mentioned Maryland's new system, which basically sets the prices of hospitals. What's interesting about Maryland from that perspective is it does have one gigantic, really prestigious hospital that is probably dominant in that, and therefore you have in order to set up a scheme like that, you basically have one entity to negotiate with.
Right.
I think it would be, if New York State tried to do that, it would be a fundamentally different enterprise.
It would.
Because you would just the complexity of it would be so much greater. But the places that hold down costs are the places where government sets prices. And even if you look across the different wealthy democracies that all have universal coverage in different ways, the ones that really have the most disciplined cost experiences are the ones where the government is most able to set aggressive prices. And there's a lot of reasons to be worried about that, but that is the way that countries have basically held costs down, and everything else that people talk about, like comparative effectiveness research and preventive care and having lots of uninsured people who just can't access care, everything else that people have talked about as ways to keep costs down are much less effective.
Right.
In the U.S., we've tried we'll just allow a lot of people to go uninsured strategy, and clearly
we well, didn't it? Great.
Yeah, we've succeeded in actually executing the thing that you needed to do to see if it worked. We did, but it didn't work.
It didn't work.
And now, one of the things that you mentioned about people's connections with doctors reminds me of something an unknown that I'm concerned about, which is what will happen with people. If you look at the segment of people who live with disabilities or have chronic illnesses or who have loved ones who have those issues, I don't think that we've really tested out how well the new exchanges are going to work. And it's partly, can you see the doctor that you want to see, but it's also, there are all of these ways that the current health system sort of has evolved to, I'm a worker, I earn $70,000 a year, I have a child with cerebral palsy, and my child has a supplemental Medicaid plan that covers a bunch of things that private insurance doesn't deal with. Maybe it's school-based services, maybe it's complicated assistive technologies that I need that are sort of beyond the level that private insurance typically does. If you go into the new exchange and you say, well, now with that income, I could actually get an income subsidy and buy a silver plan or whatever, you actually can't get a supplemental Medicaid plan the way that you could with your employer. And there's a series of really complicated issues like that nobody's even thought about yet, because we just haven't had enough people going down those paths. And I am nervous that I actually think Medicaid, for people with really complicated problems, Medicaid is probably better than private insurance for a lot of people because Medicaid just had the responsibility to do it for a long time. And a lot of states are really hoping that the new exchanges can, will be able to assume these types of tasks. And it's just completely unproven, what this is going to look like and how that's going to work. And I suspect that, when as things move forward, that there's going to have to be some sort of real modifications to deal with these issues.
Yeah.
And that's going to require Congress to actually do some stuff. And it's not clear that Congress is able to do some stuff. But when CHIP, for example, the Children's Health Insurance Program, is reauthorized, I think there'll be a real question about how do you make this work with ACA. I think a lot of people thought that you didn't so much need CHIP once ACA were fully up and running, and that's just not going to be. That's really not going to be the case for a variety of reasons.
Right.
I want to shift gears a little bit and also be efficient with your time. I appreciate your willing to come on my program. So this is Curbside Consult. I'm Harold Pollack talking with Jonathan Cohn, and let's shift to what to look for in 2014. And one basic question I want to ask you is this death spiral potential issue. How worried are you that we're just going to find that the mix of people who've signed up for insurance is just going to include too many sick people and not enough young and healthy people?
Right. So I think there's two questions here, which is, are we worried that the risk pool won't look good, right? And then are we worried about if it doesn't look good? Because let's separate those two, right? So first question, are we going to get a good risk pool? And again, my answer is I can't be sure. I don't know. If I had to guess, looking at the information we have now, I think it will be good enough in most places. And that's a very wishy-washy statement, but let me explain what that means. There's not some, everyone knows anything about insurance, and if you're on this call, certainly, and you've made it to minute whatever we're in, you know this. You need healthy people, a lot of healthy people paying in premiums so you have enough money to cover the costs of the sick. That's Insurance 101, right? Just because that's the case, that doesn't mean there's some magic number and either you hit it or you don't, and if you hit it, you're fine, and if you don't hit it, the whole thing falls apart. That's not the way these things work. What's happening is insurance companies have set premiums. Now, when they set the premiums, each insurance company made a guess. Where do we think? What kind of people do we think we're going to get? And every insurance company did this a little differently. They made a guess. And then they're going to get people, and they're going to look at who they got. And we don't yet know. We know that so far we don't have as many young people as you could have. If you had a good representation, if everybody signed up who was in the market, there would be many more proportionally. We see many more young. The estimate running around of about 40% is a good enough proxy. It's not what the number isn't what people think it means, but let's use that. And we're at like 25% now. So we're a good bit under that. But, the insurance companies presumably didn't think they were going to get to 40%, and they set their prices accordingly. And they also, insurance companies live year to year, but they understand that, this is a long-term project. I thought it was interesting, Sarah Cliff, who's been out at the meetings from the JP Morgan Investment Conference where all the insurers were. And it sounds like mostly, not all, Humana last week had said, it looks a little, worse than we thought. We're getting more sick people. But then, Cigna and WellPoint, I think. Well, no, Aetna and WellPoint both said, no, it looks okay to us. Whatever. They're talking to investors. Maybe they're kind of putting a good spin on it. Who knows? It doesn't sound like I'm not hearing myself in conversation. I'm not a lot of panic about this. If it was really bad, I think we'd be hearing a lot of panic. So that tells me that it's probably okay. One thing to remember, though, is it's 50 different states plus the District of Columbia, 50 different, sets of risk pools. So, I feel pretty good about what it's going to look like in California, New York, the big states, the ones where we know they're going to get a lot of enrollment. what's going to happen in a small rural state that hasn't really pushed this hard? It's just the numbers aren't very big in those places, so you kind of wonder what's going to go on there.
And presumably there's just more variability.
A lot more variability, right? I mean, you just figure the law of averages, right? That between the Dakotas and a few places like that, you're going to get some places that are going to, you're going to get some kind of weird numbers. Now, so that's the question of whether you get the mix or not. But now we get to, so what happens then?
So let me put a pause in, and again, this is Curbside Consult, and this is Harold Pollack talking with Jonathan Cohn. People sometimes talk about the 3 R's of the Affordable Care Act as in connection to the risk pool. Can you tell me say a little bit about that and how that fits into how anxious I should be about the sort of possibility of a death spiral of sort of sick people signing up, leading to increased premiums, leading to more sick people and fewer well people signing up, etc.
The death spiral monster. And by the way, as someone who has, when we had the whole debate of individual mandate, the argument for the individual mandate was you didn't want a death spiral. So I don't want to diminish this. I mean, it's a real danger in any insurance system. And I think it's easily exaggerated as something that's an on-off switch, as an either or, when in fact it's more of a spectrum. Bad thing. The more that you have this effect, the worse the prices get. And certainly in the long term, to imagine a sustainable system, you really do, over the course of several years, you need to get to a place where you have a good balance of healthy people and sick people. You need that eventually. The question is, how quickly do you need it, and what happens if you don't get it right away? So the law, when you design an insurance system, and this has been known for a long time, you can build kind of protections into the system to protect both. There's always a possibility some insurance companies will end up with really healthy people and some won't, right? Partly because game the system, right? I mean, in the old days, this was very common. You're an insurance company and you want to get really healthy people. What do? Well, you give really big discounts if you join a health club, right? That's not so much.
I can't say I've seen too many. Well, free wheelchair. That was not something that insurance companies generally offered. And if we're basically saying we don't want them to have a business model that profits from the health mix of the people who sign up.
Correct. So there are 3, and then in addition to that, you do want to guard against the fact that we are moving from a system. We're moving from a system that had a place where companies could, pick and choose who they insured, largely in most places, to one where they can, and where and we don't know, the introduction, how quickly, everyone knew it was going to be a couple years to phase in the enrollment. So you wanted to protect insurance companies. You wanted to make sure that you wanted to give them the confidence to offer low premium without the fear that if they got it wrong, they'd be on the hook.
Yeah.
So you do 3 things. So first of all, what you call the wonks, you and me, people like us, we call the 3 R's. I've actually been calling them shock absorbers because I kind of feel like that's a better, that's a kind of metaphor for what we're really talking about here. To kind of smooth out the transition. The first is what's called risk adjustment. Risk adjustment. All of these, none of these were invented for the Affordable Care, been used before in various places. The most common is risk adjustment, and all that says is basically, we're going to sort of look at who goes into the different plans, the plans that are getting the healthier people. We're going to take a little money from them and give them to the plans that are getting the more unhealthy people. Just so don't try to. It's partly to prevent them from gaming the system, sort of warning them in advance. Hey, you're not going to be able to make money that way, and partly to compensate if it happens anyway. It's interesting. Countries that do this include the Netherlands, and when in studying that system over there, one of the interesting things I heard was that the risk adjustment worked so well they actually overcompensated, and so there were insurance companies competing to enroll the diabetics because you actually worked out pretty well.
Well, if you're good at if it's properly risk adjusted, and you feel that you're good at managing the care of people with diabetes, then that becomes a profit opportunity. Now, one of the uncertainties is always, well, within the diabetics, there are the people that have certain characteristics I can manage well, and the people who have sort of significant socioeconomic challenges, I'm less successful with those people. So within the diabetics, I might play games about who I really want to attract and who not. And there's always that level how effectively can I truly risk adjust. But in
Right.
principle, if you really could handle this problem, and we really could pay companies more if they have more cancer patients. Some of them will decide, hey, we could make money by taking the most complicated patients and caring for them in a more economical way.
Right. And that, like all of these things, you can imagine a sort of worst case scenario and you can imagine a best case scenario. The one you just described to me is a win-win, right? Because we're providing the care for less money. It's probably better care, or at least as good care, right? That's good, but there's a worst case scenario, right, which you discussed. So that's risk adjustment. So then we have something called reinsurance. Reinsurance, sort of a similar principle, but operates in a different way. But it's really more on a kind of person by person basis. And it basically says to the insurance companies, when you get people who run up a lot of bills, we'll cover some of those costs. We'll create a pool of money that basically covers those costs. Now, reinsurance is something, again, that exists in the market today. Large employers who provide health insurance for their employees, that's called self-insuring, right? And typically what that means is they hire an insurance company to run the insurance, but the money's coming out of the corporate treasury, basically. Now, they don't want to be, they get nervous. Even if I'm a large company, I get a couple people with transplants. That's a lot of money. Transplants are sort of at the high end, right? Or you get someone with a kid, a premature baby in the NICU. So you think about places in the hospital where bills just boom, right? You're looking at,
if you have a $6 million kid, $6 million expense for something,
right.
There's some need to even among the insurers to kind of spread that load around.
Right. So they get reinsurance. It's insurance for insurers, basically. It exists in the private market today. Basically in the exchanges, the government provides it. Now, it's important to remember, reinsurance is literally an insurance program for the insurer. So it is designed. The money paid into it is paid in by all insurers. Even those not, even employer plans pay a reinsurance fee. And that money is then given to the plans and the exchanges that have, caught those people with the very high expenses.
So is it right? So both the risk adjustment and the reinsurance are basically ways that insurers redistribute among themselves monies that are provided through premiums. So it's not as if the government is spending a lot of money doing these things. It's reallocating.
It's reallocating. And I'm going to talk for a second about how you should think about that money, because all money in the end does come from one place. It's no free lunches, but there's an important. We'll get to when I get past the third R, and then there's a kind of.
Sorry, go ahead.
So the third R is something called risk corridors. This is not something you see as much in the private sector, but it's something that exists in government programs. Medicare. The drug program has a risk corridor program built into it. Overseas, Netherlands and Switzerland, I'm like 99% sure, both have risk corridor programs. And basically what a risk corridor program says is that imagine, it is sort of constructed like a corridor, and that it basically says, look, to kind of improve stability and to assure the insurance companies that, they can kind of survive in this, we're basically going to say, a certain range. If you guys are guessing at premiums, and if the premiums turn out to be pretty much what you guessed, give or take 3%, fine, you're okay. If they turn out to be way off by more than 3%, we will start to pick up half the cost, or we'll take half the profits. Basically, we're going to share this with you. So you end up, with it turns out that you look at the afterwards, you look the claims you paid out, and it's like 5% higher than you thought. All right, that first 3% is on you, but the second 2%, we, the government, we'll absorb half of that. Okay. Flip side is if you end up to the good, right? You set your premiums, and whoa, no one used medical care, and so you got this unexpected, your premium, your expected claims, they were actually 5% lower than you thought. All right, 3%, good for you. You got lucky. You keep that money. After that, we're going to take about half of that money, and we're going to use. Basically, the idea is that one pays for the other. And as it gets higher, as you get above 8%, at that point, the government shares in 80%, not just.
From a taxpayer perspective, that's a little scary. Doesn't it sound like we have a certain risk that we're really, if it's way off, that if they set the premiums way too low, that that we'll be on the hook for a big bill?
Right. So this gets right into the argument that you're hearing from the right, that this is, we're going to have this huge bailout of the insurance industry. But here are the three things to remember. First of all, again, it works both ways, right? It is a program that the government shares in the profits and in the losses. And for that reason, the CBO, the Congressional Budget Office, when it estimated the impact of this, it said it didn't come up with a separate cost estimate. It said, we think this will balance out. We think insurance companies, some are going to guess right, some are going to guess wrong. And of those who guess wrong will guess too high, some will guess too low. More or less, it'll even out.
So if insurance companies are good at their job, they won't wildly misprice their product.
Correct.
That is the assumption that the Congressional Budget Office is making.
That is correct. Now, that was the assumption. Assumptions frequently turn out to be wrong. And obviously, we have had some problems with the system. We have, and it's not clear yet whether that's going to affect the enrollment mix. Again, this goes back to something we discussed earlier. If you list the insurance companies saying things are looking roughly right, but, maybe, who knows? Who knows what's going to happen in the next 3 months? Maybe they maxed out and maybe no more healthy people will sign up and every sick person in America is going to go into an exchange. So who knows, right? Mm-hmm. So what if they're wrong? So you look at the numbers, and I want to tell you, I think I've spoken to every actuary in the United States at this point because I just wrote about this. Mm-hmm. And the great thing about actuaries is they know a lot. The terrible thing about actuaries is they refuse to put their name by something like they can certify as true. So I can't get anybody to kind of give me this is what it will cost, this is what it won't cost. I will say this, and I haven't written this yet, and I'm even reluctant to say it on the air, but I'll just sort of say this, that in general, if you work with the numbers and you use what would be a kind of realistic assumption of large losses, and you kind of massage the numbers, it's really hard to get a total payout in the first year that's more than $1 billion, $2 billion, and that's
$1 or $2 billion is kind of the upper range. And to put that in context, how did we put that $1 or $2 billion in context?
This is a $1 trillion bill. The money spent on the exchanges every year is, it's $20-30 billion in subsidies. So that is not a lot of money. And here's the key part, and this is the sort of the clinch that sort of puts this in perspective. And this one is a piece of news that has gotten very little attention. I blame myself because I haven't really written about it. So, hopefully I'll write about it before the whole world sees this video, and I won't scoop myself. Although I did mention it in my last piece.
There you go.
If you think about it, why would there be a big payout? Like, what would cause this to happen, right? What's the mechanism that causes a large risk corridor payout? Well, it's the fact that the insurance companies set their premiums too low, right? They set premiums high enough to account for the medical expenses. Now, if you think about that, and whether you think that was the right thing to do or the wrong thing, whatever moral judgment you want, this is what's causing the payout. Let's assume I'm wrong, and actually, you could get a payout of $5 billion, $7 billion. Well, here's the thing. And again, I don't know why this hasn't gotten more attention. I blame myself. Those lower than expected those low premiums, they came in way below what the CBO projected. Uh-huh. That means that the dollars that the government is spending on subsidies to help people buy insurance is going to be a lot lower. And the money the government is saving on those subsidies is bigger than the money that will go out on the risk corridors. So if you think of those two things as joined as the hip, which they really are, because one caused the other. If you didn't have one, you wouldn't have the other. That's still a net gain to the taxpayer.
So it's possible that suppose that it turns out things are more expensive. It may be that the government pays out less through the risk corridor mechanism than it would have paid out under this hypothetical if the premiums had been higher to match those costs.
Exactly.
And the underlying question is how expensive are these people to take care of, not this risk corridor program.
Exactly. That's actually it's a wonderful way to put it. In effect, that's a reality that's not going to change fundamentally, right? These people are so expensive to carry. We're all hoping this law changes the way we do medical care, and there's some signs that's starting to change, but that's a 10, 20-year process. Fundamentally, these people, here's how much they cost to insure. And basically what we're trying, that money is going to be spent by our healthcare system. And it's a question of whether it gets spent, on the front end of insurance or on the back end, premiums versus risk corridors. And frankly, unless I'm really wrong on the math, and like I said, I don't want to, don't anyone watching this quote, because I'm still trying to figure this out. I'm pretty confident this is right, but obviously not confident enough to put it in print. I think the way it's structured now, probably the taxpayer comes out to the good, probably by quite a lot.